Good. Good afternoon, everybody. Sorry I came in between you and lunch. We'll try and finish as soon as possible, or we will stimulate so much interest that you forget lunch. Because if you are interested, you are likely to forget sleep and lunch both. If you are not interested, you will sleep. So either way, there is this thing here, you can take a photo of this abstract. You might not have received. I'll just pass it on. You take a photograph of this and it gives you some information to start with. Okay? Just pass it on. I thought I will sit and speak that side, but it is no use because you won't see who it is and you will have no interest. Only when you start seeing them, you will understand. Now, I will ask three people to first present their experience with orthoptek. Can you all see that thing there? The black screen? No? If you come later on, if you come closer, I'll show you the screen, how to use it. The machine looks very simple and using it is even simpler because a 4-year-old child can use it. But to understand why it works is the most complicated. So I'll not go into why it works in detail because that will put you off completely, put you off the machine also. So I'll not go into that. First what I will do is, there are 3 speakers who will speak to you about their experience with orthoptek. Amitava, you are sitting right at the back. You can come in the front. Okay, the first speaker to share her experience is Dr. Reshma. I had earlier on put Arvind's name, but then I thought ladies first. So also Reshma was the first person who was convinced of my argument that it works, and she bought the machine and she has treated hundreds of patients. You didn't even argue, but still ladies first. So Reshma will talk about her experience. She has paid money and bought the machine, so nothing to do with financial interest. Reshma first. You can come there.
To present my cases in this instruction course. So why I feel it is a wonder gadget? Amblyopia is a lazy eye. It is a condition in which one or both eyes have weak vision. This weak vision is because of the poor development of the vision centers in the brain. Amblyopia is treated with patching as originally we've been taught in the books. So we patch the good eye and the weak eye is forced to see the things. But we see a lot of patients who complain and the parents also complain and the compliance is very poor because patching, the patient is very uncooperative and not going to keep the patch for more than 1 hour, and we require to patch almost for 6 to 7 hours if we want to achieve that good vision. Patching helps in stimulation of the various vision centers in the brain and hence the vision improves. So we have treated anisometropic amblyopia, bilateral ametropic amblyopia, meridional amblyopia, strabismic and the stimulus deprivation amblyopia in frequency of the patients that we got with orthoptek. Recently, there are a lot of computer exercises which are introduced where both the eyes as well as the individual eye, we can do the exercises which ultimately improves the vision by stimulating the vision centers in the brain. Retina is stimulated by continuous stimulation or focusing of the green and the red light and hence the center in the brain is stimulated with the help of the orthoptek machine. In the orthoptek machine, multiple areas in the brain are stimulated which helps in improvement of the vision. The prerequisites are it is a closed room, the machine is installed at a distance of almost 2 meters in the ambient light and you can see the red light, the central light, the patient has to look or focus at the central light and the pointer he has it in his hand and the various peripheral lights he has to keep on superimposing them with the pointer which is there in his hand. we will discuss some cases which we got good results and improvement in vision and stereopsis. So this is the first case of anisometropic amblyopia, a 11-year-old male who had decrease in vision in his left eye, poor vision in his left eye. Even on TNO stereopsis chart also he could not read the first plate. The cycloplegic refraction was minus 0.75 at 180 and left eye was minus 2.75 sphere with minus 3 at 180. After giving 25 sessions of orthoptek, his vision was 6.6 in both the eyes and TNO stereopsis also improved and he could read all the three charts and the patient is orthophoric. Next, coming to the meridional amblyopia, this girl, 7-year-old girl, her performance in the school improved drastically, not only because of her patching and orthoptek exercises, but her daily activities, her crankiness, her handwriting, it improved drastically. Her refraction was minus 3.5 at 180 and minus 4.25 at 180. And her TNO stereopsis was also poor, but after 15 orthoptek sessions, her TNO stereopsis improved and her report card showed there was development in handwriting and her excellent behavior. So her mother was very impressed, and the reason behind is because the hand area is close to the frontal area in the brain, and hence stimulation of the eye area also stimulates the hand area, and we are coordinating it with the hand, that is we are doing the stimulus or active participation, that is pressing the button, superimposing the light, stimulation. It helps in the hand-eye coordination and improvement of handwriting. Third case was ametropic amblyopia, where an 8-year-old child had significant poor vision, right eye 6/9 and left eye 3/60. And TNO stereopsis was also 400 arc, left eye suppression. Cycloplegic refraction was +5 with +1 at 80 and +5 at +0.5 at 90 in the left eye with 624 vision. With 30 sessions, his vision improved and he was much better. Then there is a case of traumatic optic neuropathy, where a 20-year-old boy who had met with a road traffic accident, his vision was 3/60. After giving 25 orthoptic sessions of 30 minutes each, his vision improved to 636. He could see the form of the letter. He could, there was no searching movements or there was no gazing at different sites, but he could, there was parallel eye or there was a orthophoric on examination. So the person was feeling much better than before. But other cases of traumatic optic neuropathy or optic atrophy did not show much improvement. In intermittent exotropia, he was a 30-year-old male. He was dentist by occupation, having -0.75 at 15 degrees and -3.5 at 160 degrees cycloplegic refraction. The patient had almost 35 prism XT for distance and 12 prism XT for near. He also had ocular migraine and used to have lot of eye fatigue and eye strain after driving for long distance and long hours. He could not work. There was no depth perception. TNO stereopsis also showed poor stereopsis, but after giving good number of sessions, 20 orthoptek sessions, the exotropia decreased to 12 prisms for distance and 6 prisms for near, and his depth perception improved. He, being a dentist, had to do root canal treatment, so the depth focus also improved and he could do the root canal treatment in his patients in a better way. Strabismic amblyopia for 25-year-old male operated for 65 prism XT, had residual exotropia of 10 prisms. We suggested 20 orthoptek sessions and the residual XT got corrected. He was a tailor by occupation and hence his near vision was very important and convergence, but his orthoptek sessions improved both his convergence, his residual XT and his working. Another patient of 16-year-old with 20 prisms XT with intermittent exotropia had vision 612, 69. She was not operated, but after giving orthoptek sessions, she was orthophoric and her vision also improved to 69. This is another case of 6-year-old male child brought by mother who had vision of 618 in both glasses with minus 2.75 and minus 3 cylinder at 180. On examination, the patient revealed macular dystrophy. The patient had bullseye maculopathy. It was macular dystrophy, and the patient could not see objects which were fallen down on the ground. He could not pick up the objects or toys. He could not see at a far distance. But after giving orthoptek sessions, he could pick up this spatial recognition part improved. He could identify his friends passing by the window, and his mother was very happy for this drastic vision improvement, which was very surprising. And he also had a head tilt, and that also improved after the orthoptek sessions. His up-rolling of his eyeballs had also improved, and it was orthophoric, and his head tilt also improved. This was macular dystrophy, the fundus picture, and the OCT also showed ISOS thinning. But that also, in spite of that OCT picture, but still we gave them treatment and he has improved. So orthoptek or magnocellular stimulation is a treatment for amblyopia. It is much better because it is actively involving the performance of the child or the patient. It is not boring for the patient. There is active participation. He has to press the button and focus or superimpose the lights. There is success rate more than 95% at a very short duration of 3 to 6 months. And after the success duration, their vision has improved, but that vision also maintains at a even after 1 year or 1.5 years. And stereopsis improves drastically. Thank you.
Thank you very much, Reshma. Now, those of you who are still skeptical, I am not surprised, because all these people who presented were skeptical and they showed their results with what it is. Now we have Amitava wants to talk. Yeah, go on. Because he was more skeptical than Arvind Kumar. So I'll ask him to talk. No problem. You can talk. Then I will come to Arvind Kumar, who is doing a lot of work in AMS in Hyderabad. He is also trying to do functional MRI after orthoptek. So let's hear our skeptic's thought.
Excuse me. Biswas, I am here from Calcutta. At the outset, I must make it clear that I do not use the orthoptek myself. It's used at the optometry department in our center, which is run by my wife. However, I was involved with the decision making of the purchase and signing the check. Well, that was way back in 2021 when Gopal kept on bugging me and our center with the orthoptek, the concept about orthoptek. We met several times, and all the time I thought, kya bakwas bol raha hai? And how can this be? We were happy with patching, we were happy with synopto for exercises. Of course, one of the things that we observed is over the years, patching has definitely become unpopular. I'm sure all of you will agree that over the last 4 or 5 years, because of social changes, patching has become unpopular with students. They face a lot of flack from fellow students to the extent of getting beaten up and getting, they snatch away the patch and all, do lots of things. And students are scared to do patching and go to school. This has become a problem. So they have an inferiority complex. The students develop a kind of an inferiority complex when they do patching. So patching, I think, has developed a problem, and when we thought that this is perhaps an alternative, and I calculated the financial financial implications and ठीक है इतना cost है if we charge he explained that if the charges are this much then yes okay I understood that cost can be recovered in a short period. So with much reluctance after working out the finances we did plan to purchase one machine and have it in our center. And initially, just to try it out, I started giving our optometry department every case that came to me, XYZ, adult, God forsaken cases which previously we thought have no prognosis, and we shifted from synoptophore. We'll give them an opportunity with orthoptek. One of the things that I noticed in the first few cases was that every patient gave a feedback that post-treatment, as less as just one session, and definitely by the third session, everybody reported that the letters on the Snellen's chart look better. That's for sure. Their reading ability might not have improved by number of lines after the third treatment, but they always said that the letters look better and sharper and easier to identify. That was universal even now. We selected initially patients of all age groups. Later on we learned how to select cases. I'll come to that. We have treated more than 80 patients in as high as the age group of 67 from one of our doctor friends, a senior friend who has amblyopia, and he's been having amblyopia since childhood, and even he got hooked onto the treatment and kept on coming every week because he felt better, and he still continues it at his age. He's still continuing it because he is sure that it has made a difference in his vision.
Sure.
Okay. Majority of the cases that we treated are, of course, amblyopia, a less number of convergence insufficiencies, accommodative insufficiency, squint, etc. There has been a significant improvement of stereopsis in more than 50%. Numbers would have been better than 50%, as Dr. Reshma said, 90 to 95%. Perhaps our initial selection of cases were not very logical. And visual acuity in the young patient group, yes, 90 to 95%. It's only in the elderly age group that is little less, and that's why the overall improvement, I have put it as more than 60%. Across all the age groups put together. So I feel now that if the case selection is made cleverly, then the amount of time that is spent, the manpower, and the sessions of exercises is really worthwhile. In conclusion, this is my last slide. It's short and sweet for you, Gopal. The orthoptek is undoubtedly a useful adjunct for a general ophthalmologist, no doubt about it. Financially viable, we recovered the cost in less than 6 months at our center. Ours is a tertiary care center in Calcutta. And it is any day better than conventional patching, any day, because of the reasons I mentioned earlier. Results are very encouraging across all age groups. The only hassle is the amount of time to be given with each session at the center. Patient has to come to the center. That is probably the only hassle. But when you look at the gains and the benefits in comparison to other existing modalities of treatment, this is worth it, Gopal. Thank you very much for having convinced us finally.
He's thanking me because I am the inventor of this. I am the manufacturer and the marketing person and everything. Now we have Arvind Kumar from Hyderabad AIMS, who will tell us his brand ambassador without any without financial interest. It will be in DSTC. I have to carry it because I didn't bring my manager also with me. So I have to carry it to DSTC, the orthoptek. There you can sit down and talk any number of questions you have, you can ask. But they charge you 1,000 rupees, which will be refunded after you buy the orthoptek. That is another incentive for you to come and use it and see it. If you can't come today, no problem. Saturday there are 2 sessions between 10 and 12 and 2 and 4 in the same DSTC area. Arvind.
Yeah. Good afternoon, everyone. And thank you, AIOS and Dr. Santhan Gopal, sir, for giving me the opportunity. So I will be speaking on all about amblyopia, the metamorphosis and the vacillation, the changes going on, the different modalities of treatment coming up, because patching is quite outdated now. So we have compared different modalities of these amblyopia management. So vision without action is merely a dream, and action without vision just passes the time. And vision with action can change the world. So it is by Joel A. Barker, and I'm thankful to all the Indian innovators who have done a lot of things in the world of ophthalmology. So what is the definition of amblyopia? It is a unilateral or less commonly bilateral reduction in the best corrected visual acuity that cannot be attributed directly to the effect of any structural abnormality of the eye or the posterior visual pathway. And there needs to be at least a difference of 2 lines in the logmar. So does it require redefinition? Yes, it requires redefinition as the alpha and the sigma female James Bond. So amblyopia definition needs to be changed. Which factors needs to be reconsidered? So excluding all other causes for the visual acuity reduction and cerebral changes, defining the functional blood oxygen level dependent MRI, methods of management, and the combination of treating modalities. Why we are sticking to a one treatment modality when we can combine 2 different modalities and get good results? So these are the other factors: eye-brain ability to process the motion, shape perception, spatial interaction, hyperacuity, contour integration, and the binocular single vision components. So we did the world's first such clinical trial on phakic IOL versus Occlutep versus orthoptek in children and adolescents for management of amblyopia, registered with ICMR. So occlusion therapy is a problematic, as sir has already discussed. So recurrence is also there. So then this Occlutep is there, that is a binocular polarized video games. So same background but enriched foreground to the amblyopic eye is given. And based on the principle that they can strengthen a broad range of visual tasks in adults with normal vision, including light sensitivity, contrast sensitivity, visual crowding, and visual attention. So this is how it is done. The enriched foreground to the amblyopic eye is given, and the games, they have a stepping up. So first they are very slow, and then later on they are fast engaging games. Then comes the latest, the orthoptek magnocellular stimulator. So this instrument has 3 rows of light LED, and central one is red in color, and the light come on and off for 150 to 200 milliseconds. And the patient fixates with the help of the green laser and points at it with a laser pointer. And the patient needs to be seated at a distance of 1 meter from the machine, and the procedure is conducted for 30 minutes. It requires very less time. So 30 minutes a day, not a problem. So these are few videos. So this is how it is done. So the patient is asked to follow the flashing of the light. The central one is the green, and the rest of the lights, LED lights, they are red in color. So to analyze the demographics and the clinical outcomes of the phakic IOL versus Occlutep versus orthoptek in the management of anisomyopic and isomyopic amblyopia in the age group of 10 to 19 years. So it was a prospective interventional study, and 69 eyes of 63 anisomyopic and 3 isomyopic amblyopia patients were randomized in 3 groups: Group A phakic IOL, Group B Occlutep, and Group C orthoptek. And the patients were followed up at day 1, 6 weeks, 3 months, and 24 months after treatment. So these were the results in demography. So from 10 to 17 years, there were 69 patients in all, and with equal female to male ratio. So in the group A, the phakic IOL group, from the preoperative, the mean and the standard deviation of the preoperative vision uncorrected to the last visit in the group A, so there was a significant p-value from 1.39 logmar to 0.11. In the group B Occlutube, 1.35 logmar to 0.11 logmar. So in all the 3 groups, vision improved with a significant p-value. In the orthoptek group, it was 1.37 to 0.11. Now coming to the comparison of the contrast sensitivity between pre-treatment to the post-treatment in 3 groups. So 1.07 in the A group to 1.66. In the group B, 1.1 to 1.65, and it was highest in case of orthoptek from 1.09 to 1.98. So there was a significant p-value as we compared the orthoptek group along with the occlutab and the phakic group. As we compared the stereoscopy, again it was more rapid in the orthoptek group, and it took largest time, much longer time in the group A, that is phakic IOL, to improve the stereo acuity. So in the conclusion, the amblyopia is a brain abnormality. It's not only an eye abnormality. So this are the functional bold MRI pictures. So in the first picture is a normal patient without having amblyopia. And the next, the MRI is of the amblyopic patient. So there is reduced oxygenation and blood to the occipital cortex. And after orthoptek and occlutab treatment, the blood, there was improvement in the oxygenation and the blood levels. So how it happens? So repeated stimulation of the magnocellular cells. So they have 4C alpha at the V1 area, and the saccadic and the attention area, they work opposite to each other. But they have horizontal interconnection. So by this way, the magnocellular, the peripheral cells, they stimulate the 4C beta. 4C alpha stimulates the 4C beta, and that's why the prosaccades are associated with maximal stimulation of the V1 area. So in conclusion, orthoptek magnocellular stimulator is a novel economical instrument in the management of anisomyopic and isomyopic amblyopia in terms of faster improvement in contrast sensitivity and stereo acuity, and multicentric clinical trials are of course needed in other amblyopia, and there are 11 other indications of this machine. So future is absolutely combination of different methods of management of amblyopia. So now what we are doing a new study, so we are implanting phakic IOL, and then we are going for occlutab or orthoptek. So those patients are improving very well because you don't have to worry about the glasses anymore. Thank you so very much. And this was a case, 56-year-old, right eye the refraction of plus 2.5, 618, and left eye -1, diopter to 6/6. The contrast sensitivity was 0.35 and stereo acuity more than 800 second of arc. So he did the exercise, and after 1 week, the vision improved to 6/6 part, 56-year-old patient. This is the after treatment. He is reading 6/6 partial line, logmar chart. Okay, they haven't connected the voiceover. And the contrast sensitivity improved to 1.25. Stereo acuity from more than 800 second of arc improved to 70 second of arc. And patient is so happy. He has undergone 24 sessions now. And after 6 months, there is no recurrence.
Very good.
Yeah. So thank you so very much.
Thank you, Arvind, for that wonderful explanation with no financial interest.
No.
There is no financial interest whatsoever in orthoptek. He is propagating the scientific truth. The scientific truth, like anything else, initially is rejected completely, then accepted by a lot of people, then rejected by a small number, and then it stabilizes at some stage. It goes through a graph. So the first thing, their reaction is it really true? I have never seen this like before. But the answer is yes, because you have never done this before. Why I didn't do before? Because I had too many headaches of dealing with so many things in life. Once I retired from AIOC, I had time to, then questions start coming. Why is this so? Then you have to read. So it took me about a year for me to understand the vision properly. What exactly happens? So there are certain points these people have mentioned. One, a rapid improvement. Number two, non-improvement also they have mentioned. And number 3, patients are subjectively very happy after 2 sessions of orthoptek treatment. Why the patients feel happy? Why it does not improve? And why the rapidity of improvement of vision? These are the 3 things I am going to tell you. And after that, it's open for question. You can do my slides. Just forward it when I tell you. So now the question of problem in amblyopia is not in the eye. Eye may have problems, but that is not the cause of not being able to see well. Not being able, because if the eye has a refractive error, you correct the refractive error, the child should see normally, but child is unable to see. So where is the problem is the question. So we have been blindly patching the normal eye, hoping that the amblyopic eye will start seeing with the fovea. It does not work like that, because foveal fixation is an active process and it is not a passive process. Just because I close the eye doesn't necessarily mean I fixate with the fovea. The brain has to work hard to fixate. You understand? So this is where we have been going wrong. We have been doing patching the eye and hoping the child's vision improves. It does not. It does not improve. Even after months of patching, it does not improve. Supposing the child, what happened? You have not amblyopias, they said. It's useful in the treatment of intermittent divergent squint. Yes, 100% I am confident that it works in intermittent divergent squint, because in intermittent divergent squint, the problem is in the attention center in the parietal lobe. And the stimulation of the magnocellular cells stimulates the attention center in the parietal lobe. It's useful in exotropia, which you saw already. It's useful when the stereopsis is lost due to any other reasons, and it is useful to improve hand-eye coordination. Here, it's a little bit of explanation is needed. In the brain, in the frontal eye field area, the hand area comes very close to the frontal eye field area. So whenever the hand moves, the eye follows the hand. Suppose the hand moves out, the eye moves out. The hand moves in, the eye moves in. It closely follows the movement of the hand. So much so that while doing the MRI or while doing the EEG, you cannot differentiate whether hand-eye area moves first or eye area moves first. They move very close to each other. So whenever you move the hand, the eye, obviously the area gets stimulated. From the frontal lobe, fibers come down to the occipital lobe. These fibers are called as top-down fibers, because the frontal lobe is top, occipital lobe is bottom. So from the top, bottom, the fibers come. These fibers go beyond the synapse in the 4C beta. So I'll come to that in a few minutes. So there are a number of other indications like nystagmus. Nystagmus, it works very well. I had a patient of 40-year-old who came, who couldn't fit the contact lens. So he said, I can't do, and with the glasses his vision was not improving. After orthoptek, he could put the contact lens himself. And he was very happy with that. He was I will come to that also. What the hypothesis behind fourth nerve improvement, sixth nerve improvement, and nystagmus. All those 3 I will come to that. It can be used in decreased vision due to unknown causes. You don't know what is the cause. Try it out. No harm in trying. It is non-invasive. No harm. If it improves, she showed you in macular dystrophy, the vision improved. I have seen myself one patient from Saudi bought his machine, he took it along with him. I don't know whether he is treating other patients with other kinds of problems, but I sold it to him. I said, okay, you can take it with you. So it improves vision in unknown causes. You can try it out. Optic nerve problem, somehow it improves the vision. These are the places where you need explanation. In the optic nerve problem, the vision improves because the corticogeniculate fibers, the fibers coming from the occipital cortex to the lateral geniculate body, You all assume that it stops there. No, it comes up to the retina. It doesn't stop there. It comes right up to the retina, and therefore the vision improves. That makes sense to me. I have seen cases where the vision improves in macular problems. Somebody said, can this be tried in ARMD? I said, I don't know. I have never tried it. But if you try and vision improves, you report it. I have no problems with that. So these are the other indications which these people gave. Where is that? This presbyopia is a problem actually. Okay, these are the some of the initial users. After 6 months, they gave the result. I asked them, what do you think? They said it's a magic instrument and it's a wonder gadget. And I have never seen anything like that in my life before. And you can see their skeptics. These are all the people who are very skeptical about orthoptek. Now, this is where the crux of the problem comes. If you understand this, you understand how the orthoptek works. There are P cells in the center and M cells in the periphery. Whenever they go to LGB, and from LGB, P cells go to 4C beta in the occipital cortex, and M cells go to 4C alpha in the occipital cortex. See, this is the visual dichotomy. They go to different areas. Okay, 4C alpha 1 and 4C beta other one. Temporal cortex, from P cells it goes further down to temporal cortex, because occipital cortex, I say, is like Manmohan Singh. He is unable to analyze any file, he will just pass it on to the high command. You please analyze the file and tell me the result. So occipital cortex forwards the impulses to the temporal cortex, which further analyzes the image and sends information to the posterior parietal cortical area in 7A, which is attention area. Whereas M cells, LGB layers 1 and 2, and it goes to 4C alpha in occipital cortex. This goes to beta, this goes to alpha. From here it goes to superoparietal area. In the superoparietal area, it comes down to again posterior parietal cortical area, which is attention area. So every time you stimulate this, it stimulates this. And from here, it goes back to 4C beta. See how it is stimulated? Every time you stimulate magnocellular cells, the attention area gets stimulated via the top-down impulses. From here, it goes to the occipital cortex back again to stimulate 4C beta as a forward, as a top-down impulse. From this area, it goes to this. Again, from the frontal eye field area, you can see here, frontal eye field area. From here, the fibers come back to the posterior parietal cortical area, and from there they go to again beta occipital cortex. And that's how they stimulate. These are normally existing fibers, top-down fibers. They are normally existing, and they can be recognized on EEG as alpha and beta stimuli or alpha and beta oscillations. From what goes from beta to temporal cortex can be seen as gamma oscillations. So the gamma oscillations and alpha and beta oscillations are connected here. If the gamma oscillations occur within 150 milliseconds, that is, if the alpha and beta coming down from the frontal cortex and from the parietal cortex, they come 150 milliseconds before the gamma oscillations disappear, they improve the fast forwarding of the impulses to the temporal cortex. This is the principle behind orthoptek. The lights which come on and stimulate the P cells must come on at least 150 milliseconds before the next light comes on the peripheral retina. If it comes later, it doesn't work. So how the occlusion works is because of this, that even though you apart the eye, the impulse may be falling on the normal eye at randomly before 150 and randomly after 150. It doesn't work if it falls after 150. It works if it falls before 150 milliseconds. That is the whole idea, and that's where these two are connected. Am I making sense to you at all? Okay, this is another one you can see. Neurotransmitter. Glutamate is the neurotransmitter in the 4C beta. Okay, 4C alpha, 4C beta, everywhere is the neurotransmitter is the glutamate. Glutamate is excitatory in nature and it is very dangerous to the central nervous system. So glutamate has to be rapidly decarboxylated to make glutamine, which is taken up by the post-ganglion, post-synaptic cells. See, this is where it becomes very tricky in order to understand the synaptic transmission at 4C beta, which is the problem. The problem may be because glutamate is not released, or maybe because a small amount of glutamate is released, or glutamate released is not very good quality. All these things can be cause of decreased vision. So even if you increase any number of impulses going from the retina to the cortex, vision will not improve. This is the mistake we have been making, that we are sending impulses from the retina to the cortex, hoping that some impulses reach the cortex. That is inferotemporal cortex. It should reach not just occipital cortex, it should reach inferotemporal cortex, because the block is in the synapse of 4C beta. Now, how did I know all these facts? I just read through that and then I realized that this must be the reason. Do I have enough papers to show you? The answer is yes. But if I give you that, you will just fall asleep. If you want to fall asleep, that is the best papers to read in neuroradiology and neurophysiology journals. So these are the top-down impulses coming from the parietal area and also coming from the frontal eye field area towards the 4C beta. And here they act as if glutamate is released. And this top-down impulses discharge beyond the synapse. That's how they act so rapidly. And why do they act rapidly? Because beyond the synapse, the top-down impulses stimulate the production of nitrous oxide. And nitrous oxide has 10,000 times affinity towards the heme component, and therefore it stimulates the synapses. And therefore the patients feel subjective improvement within one session. They say, I can see better. It's some kind of magic. It's not magic. It is something to do with the top-down impulses. Okay? So our senior said, Sarvendriyanam Nayanam Pradhanam, which makes sense. You have learned Sanskrit, it makes sense. You have not learned Sanskrit, you have learned English, it never makes any sense, because you can see how the occipital area is connected to every other area in the brain. It's not just occipital, retina is connected to occipital cortex. No, occipital cortex itself is connected to thousands of areas in the brain. So when you do fMRI, these are all the areas which get stimulated as soon as you stimulate retina. So you can't imagine retinal stimulation alone improving the vision by patching the eye. These are the things. If you have any more information you want, I think I am almost coming nearer the discussion time. If you have any more questions, any more doubts, you still have plenty of time. You can ask. And if you come closer, I'll show you how it works. Simple, very simple mechanism. You can come in groups, or you can come all of you. Hello, excuse me, friend. Just keep it light is alternating with green light. Can you see that? Wait 1 second. Now you see, red is alternating with green. When you are concentrating here, this comes on. That means peripheral retina is stimulated. Correct? And you move there, this comes on. That means again peripheral retina is stimulated. Now how do you move it there? What makes the brain understand that the red light is there? You understand? Because whenever the peripheral retina is stimulated, the peripheral retina does not have the analyzing capacity. It says, boss, something goes somewhere. I don't know what it is. Where? Here, I am seeing it, but I don't know what it is. Because the peripheral retina has better position sense. Then the fovea says, okay, let me take a look at it. So then the fovea says, boss, you tell me where to go. I don't know where to go. I know I have to go, but I don't know where to go. The brain says, hang on a minute, let me calculate. The peripheral retina and central retina are interconnected at different parts of the brain. They are all interconnected. They are not separate. They are not separate entities. So then the brain looks at the peripheral stimulus and says, okay, you have to move, abduct the eye by this amount and elevate the eye by this amount. And then the eye moves. Because the brain computes the distance between the peripheral retina and the fovea and sends impulses to the motor cortex to say, move the eye by this much. All this information happens within a few milliseconds. It takes more time for me to explain that than for the brain to move the eye. You understand? So the brain moves the eye. So which means that fovea is already aware of what is the object in the periphery, although not fully. So when the fovea focuses, it gets, now I know what it is. But in amblyopia, fovea doesn't know because it cannot pass on the information to inferotemporal cortex due to a synaptic block. When it cannot pass on the information, you can come closer, you can see. Due to synaptic block, inferotemporal cortex is the one which analyzes. So it can't analyze. If it can't analyze, you can't see. Although it is coming up to the synapse, it's not going beyond synapse. If it's not going beyond synapse, it's dying there. So brain doesn't want to get damaged due to glutamate, so it suppresses. Therefore, the action potential from the abnormal eye is completely suppressed by the brain. So that even if you close the normal eye, it does not move, it doesn't help. That's why patching we have been following for thousands of years without understanding anything, and blindly we are patching the eye. And somebody told me you have to patch aggressively. What do you mean? You hit the child once before you patch? That is being aggressive, no? So some of the terms you use aggressively patching is because we are not conversant with proper English. They say a lot of things, but in English the problem is each word does not mean what it is meant to mean. It may mean anything. So this is the principle based on which it works. Peripheral, and this is program 1 where you are using the hand-eye coordination. See that? I have to move this wherever the light comes and put it on the light. Can you see that? This is program 1. Here, two things are happening. One is hand is moving to where the light is, like that. Which means that I am moving the eye and the hand at the same time. It improves hand-eye coordination, improves handwriting. In 2 days, the children feel very comfortable. It improves leg coordination also. You'll be surprised how. I'll tell you an example later. But this is how the hand-eye coordination improves, plus the vision improves by doing this. See this? If you do that, even my handwriting improved after doing that. It was very bad. So I started doing that. My handwriting also improved because hand-eye coordination is important for handwriting. And many games is important. This is program 1. Now what you do is you just gently press that. Now it becomes program 2. Here what you do, keep looking at the green light. Ignore the red light. But keep counting the red light. See, if I am looking at the green light, I can still see the red light. I am not moving the eye, covert, but I am still aware of the red light in the periphery. Yes? And I am counting that like 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. I can count how many times the light comes on even though I am looking at the central light. So that becomes covert attention. The attention of the occipital cortex is drawn to the red light, but the occipital cortex is sending inhibitory impulses via the attention center to the saccadic generation center and forward to the frontal eye field area so that the eye does not move. Which means that during the time you are not moving the eye, still you are stimulating the occipital cortex. You understand the mnemonics of it. So then I realized, is it important to not move the eye? Sometimes you can let the child move the eye also. It stimulates attention. And also, see, 91, 92, 193, they can't count like that. They become very breathless. So count up to 20. Then again start from 1, 2, 3, like that. If you count, you know how many times the child is counting and for how long the child is sitting in front of the machine. If you don't count, I don't know for how long the child is sitting in front of the machine and concentrating too. Just sitting in front of the machine is of no use. You must concentrate. It is like taking this and putting it in the book. It doesn't work like that. You have to put effort. It doesn't work. That is exactly the reason why I said in some patients they said they did not improve. The next question I would ask, okay, it did not improve. Is the fovea normal? Do an OCT, particularly Heidelberg OCT. If you do, you will realize that fovea is hypoplastic. It doesn't work. It does not work. The vision improves up to a point and doesn't improve beyond that point at all in foveal hypoplasia. Then another group of patients where it does not work is in congenital cataract, where if you do multi-point EEG, you realize that the alpha and beta oscillations are reduced. There it doesn't work. The alpha and beta oscillations come from the top-down impulses. And if they are not there, vision will not improve. But nowadays, nobody is doing in India 128, 256 points EEG. You have to do 256 points EEG, then only it helps. To identify those where it does not work. Now, instead of knowing all these things, all you need to know is how to buy it and how to use it. Don't bother about the philosophy behind it. It's my child. I am very happy to describe my child in front of everybody. They'll say, "Kya bakas bol raha hai child ke bare mein?" No, there is no use. Machine counter reh ke kya karoge aap? What we are? No, that doesn't matter. As long as the patient counts 800. Or somebody moves there, he looks, who is very interesting, what is happening there and all. So what? 1,45,000 for Indians. 1,45,000. Yeah, buy it. I will give you this for half the price. Huh? Sunday only I cannot give you today, Sunday. Okay, so this all there is to this machine, but 1 year of concentrated reading has gone through it. What I have explained to you, you will not find in one place. You need to read multiple journals, then you will find it. Now you have any doubts? You are free to ask. What's the time?
Is it used for specific cases?
No, all cases. Every case you use program 1 because you want to improve the hand coordination. Use program 2 because you want to improve the vision. The program 1
30 minutes.
30 minutes session. 15. Every day you have to do it for 2 weeks. Now why 2 weeks is the question. That's a very tricky answer it has got. The nitric oxide released in the synapse. By doing this exercise, in the synapse in 4C beta, nitric oxide is released in the brain. Can you imagine nitric oxide being released in the brain? This has what is called as long-term potentiation effect. LTP it is described as in neurosurgery. That is, it makes this thing to grow back in the brain, terminals, axonal terminals. And therefore, the effect not only lasts longer, but is sustained. Even after you have stopped the exercise, it's sustained because of long-term potentiation effect. And the long-term potentiation effect does not start for 2 weeks. It starts only after 2 weeks it starts. So minimum 2 weeks you have to do. After that you can cut down. No. Normally occluded for 15 minutes. Then do it with only amblyoptic eye. And then do it with both the eyes for 5 minutes and do it with the normal eye open only for 5 minutes. What if vision is good in both the eyes? No problem. Do it equally in both the eyes and in each eye equally. Intermittent divergent squint, both the eyes may have equal vision. In which case you do with the right eye 15 minutes, left eye 15 minutes, both eye 15 minutes.
So minimum vision when we are going for the amblyoptic eye.
Counting finger.
From 1 meter distance, how will be able
They will see. For 2 days they won't see. Then they will see.
So what is the cutoff, like when can we stop? What is the end?
Vision improves, stop.
counting finger?
Counting finger vision I have seen.
Half feet, 1 feet, I mean, what is the criteria?
Okay, I'll show you this video. Video दिखाओ भैया. Show me that video. Is there? There. ये वाला देखो. Okay, this is the child who is no, ये वाला देखो. ये वाला. This is a 3-year-old child with intermittent divergent squint, ophthalmologist's niece. And I decided this child cannot point out the laser, the child may look at the laser light. I said, no problem. With the finger, keep eating chips in one hand, and with the finger keep showing the light. See what she is doing? And after 3 weeks, her intermittent divergent squint was reduced to exophoria. She was worried whether we need to operate on her. I said, let's wait for some time. See, this is what I do in very young children. Basically, you need to point out the light. So you point out light like this. Yes. Sorry? I have given a long explanation as to why the eccentric fixation is a misnomer. It's rubbish. To tell you frankly, what you people diagnose as eccentric fixation is all wrong. I try in eccentric fixation, it works equally well. I need half an hour to explain to you the whole process. But it works in eccentric fixation also. Okay, so that's how the child does with, and this one is another child who is happy doing you can see that. I had to tell her repeatedly, don't look at the green light in your hand, and see, child does it herself. She comes, sits, puts the occluder herself behind the glasses and starts doing the exercise. You don't need to do anything. Sorry, when?
When to access the vision?
Every day before exercise, you assess the vision. Every day. Give this here, specs. Yeah. And if the yeah.
If the patient is not improving,
Check why it is not improving. Do a foveal OCT and see if there is a problem.
how long can we continue, sir, maximum?
Minimum 3 weeks you can continue. If it is improving, it will improve. If it is not likely to improve, you can forget about it. It won't improve.